Welcome to Legal Nurse Podcast. I'm Pat Iyer. This is a podcast that has been sharing content with you, tips, strategies to help you in your business, which I started in September of 2016. We are now in our 9th year, and we love sharing information with you to help you in your practice. Mark your calendars. Our next online conference is taking place February 27, 28, and March 1 of 2025. We have our act together. We've got this conference planned for you and available for you to reserve your seat at the lowest rate by going to lnc.tips/February 2025 virtual. That link again is lnc.tips/February 2025 virtual. There's no spaces in that link at all, particularly between the February and the virtual. lnc.tips/February 2025 virtual. We'd love to have you join us at that conference and get the benefit of the expertise of our speakers and our topics, all designed to give you the knowledge, the support, and the networking that you need as a legal nurse consultant. And now, let's get on to the show. Welcome to Legal Nurse Podcast. I'm Pat Iyer, and today we're going to talk about a condition that can occur to obstetrical patients that can completely alter their plans for having any other children, and that is Placenta Accreta. I have with me as my guest a woman who is a certified registered nurse, legal nurse consultant, and expert witness. She has over 13 years of experience of nursing, and she's been involved in doing some research and presentations at conferences, and specifically the Association of Women's Health, Obstetric, and Neonatal Nurses. Incidentally, Katie, my guest, Katie Roberts, my first article that I ever published was in the journal for your association. I talked about my experiences having a premature baby and some of the stress associated with that experience and some of the recommendations that I had for nurses in treating parents who are going through that type of experience. So it's a group that I know a little bit about, and I can envision the cover of that journal even as we're talking. Welcome to the show.
Thank you so much. It's a pleasure to be here. Thank you for inviting me on.
When you and I first talked about doing this, I had in my mind a confusion on a placenta previa and a placenta accreta. So let's talk about what is a placenta accreta.
A placenta accreta is basically an abnormal implantation of the placenta. Normally it just attaches to the inner lining of the uterus, so it can easily come off after delivery. With the placenta accreta, it embeds further into the muscle of the uterine wall, meaning it will not detach after delivery.
And are there risk factors for women developing that condition?
Yeah, so funny enough, when you talk about placenta previa, that is one of the risk factors of placenta accreta. The biggest risk factor of all in developing placenta accreta would be a history of prior C-section. And the more C-sections that a woman has, the higher her risk of having an accreta. The thought process is that the scar from the incision where they do the C-section, that leads to an abnormal implantation of the placenta. So the biggest risk factor of all would be the combination of the two. So if you have multiple prior C-sections and now you have a placenta previa, so your placenta is overlaying the cervix and then also overlaying where that scar tissue is, when you have those two in combination, they can drastically increase your risk of accreta. Other things that may increase your risk would be any kind of surgery on the uterus, a DNC, if you had any kind of radiation. There's a condition called Asherman syndrome where you can just spontaneously have scar tissue in the uterus. Any of these things can increase your risk of having placenta accreta.
Is there a theory as to why C-sections are more common now?
That's a loaded question. Why are C-sections more common now? There's probably a few reasons. Yeah. One, they look at, we do have in some sense is older moms having children when they're older, more health issues than historically. There may be literature on fetal monitoring. Does fetal monitoring actually improve outcomes, or are we doing more cesarean sections because of what we see on the fetal monitoring tracing? But overall, the largest increase in the overall number of C-sections people are having probably starts with that first C-section. So once you have your first C-section, you have the option to trial a vaginal delivery after that, but more often than not, you are going to have repeat cesarean sections. And those repeat cesarean sections are really what put you at risk for having an accreta. And that's why a lot of the focus nationally has been on decreasing the percentage of first-time low-risk moms who have that first cesarean section. So we're not setting them up for kind of this cascade of risk.
I was talking to a woman who's a yoga instructor in Colorado earlier this month, and she told me that half of her class were women in their mid-40s up to 50 who were having babies for the first time.
Yeah.
There was a nurse practitioner who was at my house yesterday. We had a pool party, and I asked her if she was seeing this in her population. She works for Planned Parenthood, but with a very different socioeconomic group of people who don't postpone having children, or for one reason or another, don't see it as an option that they can postpone children until they're older, but they have them much younger. Perhaps that's also the population we're talking about in terms of trying to prevent C-sections in younger women.
Yeah, it's a hard area, I would say. And there's so many different factors that go into why a woman needs a C-section. Maybe the reason why our nation has kind of struggled to decrease that rate, very multifaceted. But I think a lot of people look at cesarean because we do them so regularly as low risk for complications and problems. And yes, we are very good at doing a C-section with minimal risk to mom and baby, and everyone looks at it as a very standard thing, which it is very common, but I don't think everyone thinks about what comes later on in terms of risk and maternal morbidity and mortality as they have another C-section and another C-section and another C-section.
Going back to the placenta accreta, at what point in the pregnancy is it typical that the obstetrician finds out that this problem is developing?
I would say usually in the second trimester, and the most common way that they would find suspicion for accreta would be on their ultrasounds. The ultrasound is the most utilized way to assess whether a woman has an accreta or is at risk for having an accreta, especially if they have these risk factors like prior C-sections, a placenta previa. They will be getting periodic ultrasounds to assess the location of the placenta, and they would be able to see things like abnormal vasculature, perhaps a thinning of that myometrium, a few different factors, which a radiologist would probably be able to explain a little bit more the intricacies. But there are a few things that they look for there that would determine the level of risk. Sometimes you can very clearly see on an ultrasound that this patient definitely has an accreta. Other times it's less clear, and sometimes you may see nothing at all on the ultrasound that would indicate accreta. Part of the planning, the ultrasound imaging, but also the patient's risk factors would be important in planning the care of this patient.
When we think about the implications of this, that this placenta is firmly implanted into the uterine wall and is not going to detach readily or easily, are there ways of evaluating how serious that implantation is?
Yeah, the ultrasound can tell you some things. So you usually can tell if it's more advanced, particularly if it's invading other organs. But a lot of times you don't fully know until you actually open up the patient for that C-section and see what you're dealing with inside. That's one of the hard things about it is, yes, sometimes you are completely surprised and sometimes you don't fully know what you are going to see when you open them up. But ultrasound would be the number one in terms of trying to assess the level of placental invasion.
And then tell us about the implications. If we look at this from the damages perspective, if we're putting it through a medical legal lens, what could possibly happen to the woman as a result of a placenta accreta?
Yeah, these conditions, it's very high risk condition and high risk of maternal morbidity even the potential for maternal mortality with these cases. The biggest complication will be a large hemorrhage, large amounts of blood loss. The most accepted treatment for a placenta accreta is to do a hysterectomy at the time of cesareans. Since the placenta will not come out, you will take out the uterus and the placenta together. Doing that surgery has its risks as well. The uterus during pregnancy has a large amount of blood flow to it. You could also have blood loss just from doing the hysterectomy itself, but blood loss would be the main thing. A lot of these women end up having preterm deliveries. So either you are planning to do the delivery preterm to avoid an emergent situation with this woman coming in the middle of the night, or they might have bleeding during the pregnancy that necessitates an earlier delivery. With obviously, if you have the hysterectomy, just the complications with the surgery itself, there's also those implications for future childbearing. They will not be able to carry children anymore. They could potentially get an ICU admission after. You could also have damage to surrounding organs. The most advanced form of an accreta is a percreta, where the placenta can actually grow into other organs. You could have placental invasion into your bladder, or you could damage things like the ureters during the surgery itself. Lots and lots of different complications that could arise for these women. So it's very important to kind of recognize when women are at risk, try to have that early diagnosis so that you're prepared for them.
Wow. So the woman who has no prenatal care, who shows up at the hospital having never had any ultrasounds, or any inkling that there was an issue with the placental implantation, is going to pose a very serious concern if it catches everybody off guard. What about if the woman is bleeding during labor? Do you see that with placenta accreta? And if so, say it's a small community hospital and they don't have a lot of resources. They might not have empty ICU beds. What's the best outcome for that kind of situation? Before we continue, I'm Pat Iyer, an experienced legal nurse consultant. What does it take to do well as an expert witness? Do you qualify to review this case by virtue of your education, training, and experience? Sometimes expert witnesses are asked these questions in a way very confrontational during a deposition. What makes you think you're an expert? You must be able to defend yourself and answer that question in a credible and logical way. If you're asked in a deposition why you think you're an expert, how would you answer? Typically, experts draw their strength from these factors. Education. Ideally, the expert is well educated. An advanced degree in nursing is desirable. The expert should have a minimum of an associate degree, ideally a bachelor's or higher. Training. Ideally, the expert is clinically certified in a subspecialty of nursing. The person has received specialized training in this aspect of nursing. Experience. The expert is well experienced in the clinical care in question. Some states require an active clinical practice within a certain number of years of the incident. If you're unsure, ask the attorney about the expert witness qualifications in that state. Searching on Google will reveal the details also about expert witness qualifications. I qualified these statements with the term ideally because there are well-qualified experts thoroughly grounded in the clinical issues of a case who do not have a degree or certification. However, when pitted against an expert on the other side, who has both the degrees and the certification, the first expert may look less qualified. Are you an expert? It's always essential to consider the nature of the case before you agree to accept it. Are you truly experienced and expert at this type of case? Were you working in a clinical area at the time of the case? Do you have a depth of knowledge about the clinical issues involved in the case? Are you comfortable in stating that you're familiar with the standard of care at stake in the case? No one is helped by you taking a case
when you cannot say yes to all of these questions. Your credibility is rooted in your yeses. It's an ethical and honorable decision to be honest about your background and decline a case that does not match your background. The attorney appreciates this response and often keeps you in mind for future cases that are right for you. Take on a case as an expert witness you are qualified to review. Get more essential tips in my book, How to Be a Successful Nursing Expert Witness, 2nd edition. It's available as an instant download at lnc.tips/creating series.
And now let's return to the show.
This goes back to the early diagnosis. I mean, for someone with prenatal care, with no prenatal care, it's going to be difficult. Just kind of have to go by their risk factors based on their medical history, surgical history, previous pregnancy history, and stratify your risk based off of that. Typically, these women would not be laboring. They would be scheduled for a C-section. That's why you try to have the earlier delivery scheduled so that they don't go into labor. Because yes, if they labor, they can have bleeding. You're kind of doing all of this emergently rather than having the team set up and prepared to deliver them. For a small community hospital, I would say if there's any opportunity to transfer the patient out, if they're stable enough to go to a facility that is able of managing large amounts of blood transfusions, has the experience handling accretas, that would be the best case scenario. The biggest thing you're going to need is a lot of blood, so a blood bank that can handle massive transfusion protocols and things like that. And that goes back to the early diagnosis. If you're unsure, if there's any question on the ultrasound, getting a second opinion would be super helpful. Perhaps transferring them to a care center that can handle them would be good. But I would say if your facility is not really set up with the manpower to handle this, if there's any possible way to get them to a facility that would be ideal, because handling it in an emergency with limited resources is going to pose a lot of risk to that patient.
Tell us about the kind of team members who would be required in this situation.
Pretty much all the literature around this shows that having a multidisciplinary approach to these patients improves outcomes. So it's really important to have a lot of people working together to make sure that this patient has the best possible outcome. So you obviously have your obstetrician. You may involve a maternal fetal medicine specialist. You're going to have your radiologists who are reading the ultrasounds, or that could also be your maternal fetal medicine doctor reading the ultrasound reports. Those go in line with that early diagnosis piece. You could potentially bring in other service lines. So urology is a pretty common one. They may place stents in the ureters pre-op to help identify them. Gynecologic oncologists are incredibly important. So they do a lot of hysterectomies in their line of work, and they also deal with a lot of surgeries that involve invasion from cancerous tumors. So in many ways, the placenta invading into other organs is similar to a tumor invading into other organs. So they have this surgical skill set that can be really helpful in taking care of these patients intra-op. A facility that is used to handling high-risk patients like this, they often will have multidisciplinary meetings that talk about those patients who are at risk and involving everybody in the conversation. You're going to have those people available the day of surgery to help as needed. The NICU team. So if you are planning on delivering early, it's really important to have your NICU colleagues aware so that they can be available for this preterm delivery. The blood bank, the colleagues at the blood bank, to make sure you have blood available for this patient are integral to their care. The anesthesia team is of utmost importance. They're going to be seeing this patient hopefully during their pregnancy with a consultation. They'll be deciding what kind of anesthesia are we going to do. Is it going to be neuraxial with an epidural, or are they going to put them to sleep under general anesthesia, or are they going to use some kind of combination? Your nursing team is incredibly important to help get the team what they need. Your scrub techs, labor and delivery nurses pretty typically do a quantitative blood loss for all their patients. So you're calculating how much blood the patient is losing. That information is incredibly important to give to your anesthesia team so that they can resuscitate this patient, give them the blood they need, give them the blood pressure medication they need, and really resuscitate and give the patient as good a chance of a good outcome as possible. And some patients, they really do. If you have a good team and you've diagnosed this beforehand, everybody there is ready, you can have a very smooth surgery with a patient who does not need an ICU admission and is discharged a few days after her delivery. So not every single placenta accreta needs to be a catastrophic event if you have the right team and the right people in the room.
That is a comprehensive team.
Yeah, it takes an army for sure to take care of these patients. Yeah, so that's again going to like the facility. You really want to be somewhere who can provide that kind of support because there are a lot of moving pieces and a lot of teamwork that comes together to optimize their care.
You mentioned blood loss a couple of times. Are there ways to manage massive blood loss so that it doesn't turn into a catastrophic hemorrhage?
I would say the number one thing, especially in terms of placenta accreta, is if you know that there is an accreta or you have high suspicion for an accreta, you really do not want to be tugging on or pulling on the placenta or excessively trying to remove it. Because if it starts to separate and starts to remove but is stuck, you're going to have a lot more bleeding from that placental bed. So you really just want to not touch the placenta much at all and just leave it inside and proceed with the hysterectomy. For low risk patients who you really don't think there's an accreta, they might have one, you could potentially try to remove it. And if it comes easily, they don't actually have an accreta, because there's that other side of things too, that the ultrasound might show something suspicious, and then you go in and they don't have an accreta and you have everybody there, but then the placenta just pops out and everything is fine and you move on. So very low risk of where the placenta is just coming, that's fine. But if it's an invasive placenta, you really don't want to touch it to minimize the bleeding from that site. If it's an anterior placenta, so if it's on the front of the uterus, which is where we make our uterine incision, you want to avoid cutting through the placenta. So sometimes, again, if you cut through that vascular placenta, it's going to start bleeding and it will continue to bleed from that spot until you get the uterus out. So it's just going to increase your blood loss overall. What they could consider doing is occasionally you will ultrasound directly on the uterus intra-op to clearly see where the placental margins are, to make sure that you are doing your uterine incision in a spot that does not touch the placenta. So that can be helpful. And I think that can help in avoiding massive amounts of blood loss. And then you're going to want to get the uterus out as quickly as possible, surgically control the bleeding as quickly as possible. But I think equally important is your quantitative blood loss, really understanding how much the patient is losing so that if needed, you can institute that massive transfusion protocol when you need it, get the blood products when you need them, so you're not ever behind in their resuscitation, to avoid things like a maternal coat, and kind of if you get behind in resuscitating, that blood loss can lead to further problems for you.
Can you explain about cell saver machines and how they're used to manage this problem?
Cell saver is something that may be used for certain accreta cases. You usually know in advance whether or not you're going to be using it for a case, but it basically is it suctions the patient's blood from the field, it filters it out, and then makes it available to return to the patient. So they're getting a blood transfusion of their own blood. This decreases the amount of donor blood that you may need and decreases complications that may arise from donor blood, like incompatibility or reactions, things of that nature. It can also be helpful for people who are not willing to accept blood products, like Jehovah's Witnesses. But it is important to remember that it is only returning red blood cells. So it does not fully give them everything that they will likely need. They'll probably still need things like plasma or fibregia or cryoprecipitate if they're having clotting issues. So it's a helpful tool. I don't foresee if they could get by with just cell saver for an Accreta case, that would be impressive. I have not personally seen it, but definitely a helpful tool in minimizing the amount of donor blood if you're able to give them back some of their own blood.
All right. Now, if we put this back into the medical legal lens and absorb everything that you've shared, a legal nurse consultant could get a call from a plaintiff attorney saying, there's a couple in my office. They say that she went in for a baby. She ended up having a hysterectomy. They think it was unnecessary. They want to have the case looked at. They can't have any more kids now. What are some of the services that a legal nurse consultant could perform in a case involving a placenta accreta?
Sure. I think merit review is one of them. So really seeing if there's any merit to this case. Be helpful to have like the labor and delivery experience or someone with that background. I think sometimes these cases, because they are so high risk, for instance, something like a hysterectomy, if they have an accreta, that likely is going to happen. So sometimes you might look at it and say they had an ICU admission, they had a hysterectomy, they got all these blood products. And the instinct is to think these are terrible outcomes, when in reality, maybe they got really great care. And this is just a natural product of the clinical situation that they were in. This is also why it's really important to educate our patients along the way about these things so that they understand what's going on and understand why these things are happening. Timelines are super helpful when we talk about the diagnosis beforehand. What kind of consultations did they have? What kind of ultrasounds did they have? Did they miss their ultrasound appointments? Did they get their prenatal care? When were they scheduled for delivery? Should they have been scheduled early and they let them go to 39 weeks and it turned into an emergency? Getting the right experts on board. So when we talk about all these service lines, the radiology experts, the obstetrician, your gynecologic oncologist, your anesthesia teammates, figuring out who was involved, who might be someone who would need to opine on this case. They often end in hysterectomy and all these different things. Does that mean that none of them have standard of care issues? No. So I think it takes really a close eye, especially these cases can be quite complex with large amounts of blood transfusions, lots of different service lines, lots of different people involved, being a high risk situation to begin with. Yeah, there's a lot of investigation that would have to go into the nitty-gritty of things to really parse out, was there a standard of care issue or not?
It certainly sounds like having a grounding in being able to read obstetrical records, understand the nuances of them, would be very helpful in working on these cases.
Yes, I agree. And they still, luckily, while they are increasing, so we are seeing more accretas now than we ever have before, likely related to our increase in C-section rate. I think we are going to be seeing, unfortunately, more of these cases in the future, but they are luckily still relatively rare in that we don't see them every day. We don't see them every week. We don't see them every month. They're still something that we are learning about. Research should be another thing that a legal nurse consultant could help with. Now that we are seeing so many more of these, I'm very interested and curious to see what happens in the next 5-10 years in terms of research, because now we have so many more patients we can look at, so many more data points to pull together. So I'm really curious to see what comes in the next 5, 10, 15 years and how our care for these women changes and what's going to happen. If you're listening to this 5 years from now, maybe do a deep dive into the research to see if anything has shifted.
That's a great point, because we evaluate cases based on what were the appropriate standards of care at the time of the incident, even if they have changed and improved since. Our defendants don't have the ability to foresee into the future and conform to the future standards of care that might be issued by organizations or developed as a result of research.
Correct. Yeah, absolutely.
Let's say a legal nurse consultant or an attorney wants to contact you about reviewing one of these cases. What would be the best way for them to reach you?
Sure. The best way to reach me would be either go to my website, robertslnc.com, which has a lot of information about me, or you could email me at katie@robertslnc.com. And I'll be happy to help out with anything that people need. I'm very passionate about labor and delivery, accretas, as you can see. So I find it all super fascinating.
Thank you, Katie.
You're welcome.
I appreciate you sharing your passion. I know that for you who's been listening to this podcast, you may be learning some facts for the first time about the implications of placenta accreta. Certainly, as Katie described, a rare condition that is becoming less rare with the increase in C-sections. So it may stimulate more requests for reviews when people are asking you for help in investigating these cases. Be sure to stick around for another couple minutes to find out what's coming up next on Legal Nurse Podcast. And go to our website, legalnursebusiness.com. Take advantage of the free reports that we offer. We would love for you to be able to get the benefit of what we can share and have success in your LNC business and LNC career. See you next week. Coming up next on Legal Nurse Podcast, we're going to be talking about a therapy that is wonderfully convenient and can work real well, and that is giving IV fluids and medications in the home environment. But there are also risks associated with that. My guest is an experienced home infusion nurse, Shannon Fenimore. She's also a legal nurse consultant and serves as an expert witness on home IV infusion cases. Shannon, what were some of the things that we covered in your podcast?
So, Pat, we highlighted what IV home infusion is and what circumstances that it would be used, what types of IV access are used at home, who actually hangs the IV, and what type of records are kept as far as home infusion records. And how often does the home care nurse provide infusion and go into the home? And what are the risks of home IV infusion? And what are the clinical reasons why a plaintiff would bring a suit in a home IV infusion circumstance? The risk of not recognizing signs of sepsis or anaphylaxis.
Thank you, Shannon. I know that this is going to be a helpful episode for our listeners who are curious about home IV infusion, what would bring a plaintiff to a plaintiff attorney's office, and some of those clinical implications of providing therapy in this setting. So be sure to click on down below or come back next week for our next episode of Legal Nurse Podcast, when you'll have an opportunity to hear about home IV infusion from Shannon Fenimore. I'll see you then. Thank you for being part of our audience of Legal Nurse Podcast. I hope that you enjoyed this session and you got some great tips from it. I would love to see you at our February 2025 LNC Success Online Conference that will be our 11th conference, taking place February 27, 28, and March 1. You can get your ticket by going to lnc.tips/February 2025 virtual. I'd love to see you there.